Welcome everyone to today's webinar, From Early Adoption to Enterprise ROI, Lessons from Nursing Deployments with AI. Before we begin, I'll walk us through just a few quick housekeeping notes. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And finally, if you have any issues with the audio or visual, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we're here to help. With that, I'm pleased to turn the floor over to Mac Boiter to kick off today's webinar.
Welcome everyone, I'm Mac Boiter, VP of Engagement at KLAS. For those who are less familiar with KLAS, we've been the independent voice of healthcare IT since 1996. Our entire research model is built on one principle. We go to the people actually using the technology, not just the vendors who are selling it. And most of our data, over 95%, comes from in-depth conversations with healthcare providers and payers, and we keep their identities anonymous so they can speak freely and honestly. A few weeks ago, we published our first look report on ambient AI for nursing 2026, and this was focused on a bridge. It is one of the first pieces of independent research to look at what is actually happening when health systems deploy this technology at the nursing level. And what we found was striking. Across every expected outcome, customers reported favorable results. Patient satisfaction went up, documentation time went down. Nurses spend more time with their patients, documentation accuracy improved, and nurse-to-patient communication is getting better. And all of it validated. Research is one thing. What I want to do today is bring that research to life through a CNO and a CNIO who have been in it. They've been making the decisions, managing the rollout, and now they're watching as those results come in. So let me introduce them. First, Misty Faust-Cofield, Chief Nursing Officer at Reid Health, and Jill Scheiplein, Chief Nursing Informatics Officer at Corewell Health. Both organizations are early adopters. Both have been generous enough to share what they're seeing, what worked, and what they wish they would have known. We're going to be going through the conversation in a few chapters, really starting with the problem, the preparation, then the outcomes, and the advice. So let's start at the beginning. Take us back to the beginning, if you would. What was the documentation burden actually costing your nurses? We'll start with you, Misty.
Sure. Thank you, Mac, and thank you for that introduction. So during the rounding time that I was spending with my teams, it was really a couple of things that stood out for me. The first one being the cognitive burden of all of the work that our nurses undertake during the time of their assessment, their work at the bedside. When they're doing that assessment and then they walk into the hallway and they get pulled in several directions. And at that time, they would have to recollect all of that information to try to then put all of that into the EHR. And it was just a very heavy cognitive load for them. And of course, the accuracy. So by the time they would get that assessment completed, go into the hallway to document all of their findings, the accuracy by the time that they were pulled several different ways, I just don't think that we were doing an adequate job because we were not documenting in the moment, real time, to get the most evident capture of our assessment. So this was really focused for myself and for Reid around clinician well-being, and it was really a trifecta in those three areas that we were able to utilize ambient to tackle.
Thank you for that. And Jill, I'd love to hear your thoughts as well.
Yeah, documentation burden has been compiling for well over a decade with more and more requirements placed on our nurses. We've tried optimization, feedback loops, efficiency improvements, and although we have seen some progress, we haven't seen the meaningful adjustments that we were hoping for. And what made this a moment that's unique for our health system at Corewell is that we had 3 systems that came together during our integration, and all were on different instances of the same EHR that came together onto one platform. And it was during this time that we saw our EHR satisfaction scores go down. Even for our experienced nurses, they felt like they were starting over. So ambient felt like a new opportunity and approach, one where those confounding factors really becomes obsolete, because many of the factors that led to inefficiency, like number of flow sheet templates or rows, or even searching for elements that might be buried within row information, whatever it was that was leading to that inefficiency, it really doesn't matter because the content is captured and entered on your behalf. So at Corewell Health, our overall nursing satisfaction with the EHR, which was measured by KLAS, was a 61.1 out of 100, with documentation efficiency cited as a primary driver of dissatisfaction. And additionally, we had 38% of our Corewell Health acute care nurses. When we looked at our survey from 2025, they had reported symptoms of burnout with EHR inefficiency, too many bureaucratic tasks, and administrative workload identified as those contributing factors. So for our pilot units, we partnered with KLAS to co-create a survey that would capture not only those standard EHR satisfaction questions, but also to capture their experience and satisfaction using ambient. And what we found for our group of pilot users was that an increase in 10 points in their overall EHR satisfaction just within 4 months of using ambient.
Thank you for sharing that. Those are significant gains. Anyone who's listening will recognize that's a pretty substantial change. And I wanted to talk about one of the critical success factors that we identified in our research, which again is ensuring that nurses are confident, are they comfortable with conversational care. The ability to verbalize assessments, the findings, talking through the plans with patients in the room. The feedback we got was that was impactful both for obviously the clinicians and the nurses, but for the patients as well, where they felt kind of involved a little bit more in some of that process. It's a real shift. I'd love to understand how you kind of approached that. How did you approach kind of empowering nurses to be able to verbalize better, to talk through those plans with patients in the room?
So our unit nursing leadership, which included nurse educators, shared 6 weeks of what we call drip content prior to go live. So drip content focused on the benefits of ambient documentation, how the technology works, tips for narrating assessments, and in using patient-friendly language. We were also very intentional with our simulation labs in giving the nurses hands-on practice time to really get comfortable in narrating their care. Our nurses were comfortable with using the technology itself pretty much right away. So the focus for SimLab was more focused on ensuring that what I'm saying is then translating into what I'm seeing after having that conversation. It was important that we gave them the amount of time that was needed to get comfortable in what they were saying and then how that was translating to documentation. Our nurses were excellent with communicating with their patients and explaining the care they were providing, but oftentimes their choice of words that, although were meaningful to the patient because it was patient-friendly language, it didn't necessarily translate into what we would need from a documentation perspective. So for example, using the word good, your lungs sounds are good or your pulses are good, isn't enough to capture meaningful documentation. So practicing that and really getting familiar and comfortable with both was important. Our goal was to have every nurse go through simulation lab at least once, but we found that the majority wanted to perform several sessions for testing and practicing before ever using it in a live scenario with their patients. And I think it's also important to mention that not every nurse was sold on the use of ambient listening. We had several nurses that were skeptical, and the SimLab was a great opportunity to take them from skeptical to curious. We invited them in. We asked that they play the role of the patient, which was a little bit more of a passive role to take on, but it gave us the opportunity to show them the benefits as their colleagues were interacting with the technology, and they couldn't deny the benefits that they were seeing play out in real time, and it didn't take long to see that buy-in shift. The nursing feedback was also very valuable to us. We had a Microsoft form that was accessible via QR code. This allowed nurses to submit feedback. They could request assistance or ask workflow questions, and that was all routed to our project team via email. And then we had a closed loop feedback process that was used for each submission just to help make sure that we were developing their trust.
You know, it's so interesting to hear you say that, Jill. Something we saw on the physician clinical ambient speech side was the importance of those physician champions, right? Where someone could get on and a physician could share, this is the impact that it had for me personally, and really espouse that within the organization. It sounds like you've taken a similar perspective when it comes to change management for the team to meet them where they are. And Misty as well, appreciate the feedback there about TikTok. I do not use TikTok myself, but I understand a lot of people do. And it's a great platform to have that dissemination, right? Which is phenomenal. So leading into that informatics infrastructure, neither of you really took that one size fits all approach. And from my perspective and the research we have, it's really the point that you've got to be looking at. Anyone who's watching this, who's trying to figure out what their version of rollout or implementation looks like, taking it more pragmatic and more, it's not one size fits all, it's what needs to work. One other thing I wanted to share, just from our research really briefly, and then get both of your thoughts on this, was we spoke with a variety of different health systems, including your teams, but some of the things that we saw were favorable outcomes across patient satisfaction. Documentation accuracy was certainly there. Time nurses can spend with their patients, and those outcomes showed up relatively quickly. Measuring them and translating them for different audiences inside a health system, especially where every health system is a little bit different, or a lot different as the case may be, it's its own challenge. So Missy, back to you here. What are you measuring and which metrics have been most useful in telling that ROI story to nurses, to nursing leaders, and really back to your executive team as well? And then Jill, would love to hear from you after that.
Sure. So we are most certainly utilizing EOS because we heard very loud and clear about the cognitive burden, about how documentation was really pulling and creating a wedge between our caregivers and the patients that we serve. So that was definitely a measurement that we utilized. Most certainly, we saw the pickup on our patient experience scores. So on our pilot unit, we were running, I'm sad to say, below the 25th percentile in communication with nurses on that floor. And many of you are well aware that the nurse communication score is a key driver in many other domains. And when we rolled this out and we were able to watch those scores transition, quickly those scores move to and are sustaining above the 75th percentile in just that short amount of time. So over about a 5-month period, we've been able to maintain that nurse communication score above the 75th percentile. And then another thing that we have also utilized is we have measured minutes in documentation. So how many minutes are our teams spending in the chart documenting their care? How long are our caregivers in there? Because every single minute that they spend in the chart is minutes that they're taking away from being and connecting with that patient. And we have seen a dramatic decrease in the number of minutes that they're physically inputting data that they had already gathered. So with a bridge, they were able to pull the data for us. And what we found was that in early adoption, around 30% ambient capture, nurses were already saving over 15 minutes per clinician per shift. And at 60% capture and above, that number climbs to almost 25 minutes per shift. And that is from a single unit across only 4 flow sheet templates. So as we continue to scale this house-wide, we only expect that number to compound. Another thing that has been quite notable is that our vacancy rate before rolling out ambient and the abridged technology was running about 18% for RNs. And I was just able to pull this last week, and we are down to a vacancy rate of 8.6% for nursing in general. And we utilize no contract staff here. So everybody knows that it costs us anywhere between $80,000 to $100,000 to retain one nurse. So that 10 percentage point drop is very meaningful to the bottom line. I've seen another thing that we picked up, and this was not something that we anticipated, but a significant reduction in incidental overtime. So that is the time that our nurses are working past shift. That is the time that they need to be home enjoying dinner with their families or making their soccer games with their kids. And we have been able to cut that time down by about 80%. On the units that we have rolled out the technology. So that has been very impactful for work-life balance and the well-being of our clinicians. And for CFO, we all know that what they want to hear about is the dollar impact, but I really have worked hard to tie it to retention and recruitment because we all know how expensive turnover can be in nursing. So those are a few of the metrics that we have used and seen great results.
Very helpful. And I love that because, yes, the dollars have to be there, right? But without margin, there's no mission of delivering care.
That's right.
But also be able to give those nurses their time back. Jill, similar question for you. How have you been able to kind of adapt that process?
We've been tracking very similar metrics that Misty mentioned. We're looking at length of stay, nursing satisfaction and burnout, our patient satisfaction through our HCAP domains, that timeliness of charting. And at a minimum, we knew it would make our nurses more efficient, but we were very curious to see what exactly that translated to. Is it time saved? Is it more thorough documentation? Is it their latency? And the immediate benefit that we were able to see was confirmation and time savings. We were also able to see that the amount of engagement with the tool made an impact on those overall savings. So the more you're using it and leveraging it to your advantage, you're going to see those time savings come back to you in your shift. So what we found was that when nurses were using ambient for 60% of their shift, they saved an average of 28 minutes per shift. And flow sheet time among our top users also showed an average of 52% reduction. So if your nurses are anything like ours, we also love to count clicks. So we found that ambient documentation accounted for 280,000 clicks saved during implementation. And that cognitive load and burnout question are the two highest response rates in our surveys. In a comparison, when we looked at our KLAS baseline against our 60-day pulse survey results, 88% of our nurses said the tool is easy to use, 79% said that training had prepared them well, and the two areas that I personally was really focused on was that cognitive load and documentation time. And both showed meaningful positive movement, with about 60% of our nurses reporting that they had reduced cognitive load and 67% reporting a positive impact on their documentation time. So what also stood out to me was the improvement in documentation latency. 79% of nurses on the units are now completing documentation within 2 hours of patient engagement, and no one is waiting until the end of their shift to complete it, which is a real shift in how we saw work being completed prior to the implementation.
And I love that these are obviously initial to semi-mature, but I look forward to seeing more of this, right? And just amplifying this across other scales and sizes. What strikes me, though, about the ROI story is that it's not one number, right? And nor should it be. There's a lot of ways to factor this, and every team's going to look at this a little bit differently. It's a constellation of signals, I think, is a way to describe it. Different audiences may have, even at the same health system, they need to hear different parts of that story, right? So for nurses, it's one thing. For leadership, accounting CFOs, CIOs, CTOs, they want to know what's the impact here on our IT queue. And we've got 15 other AI technologies we're trying to deploy. How do we make sure that this is that impactful? One thing I wanted to get to is something that's a little bit harder to quantify. How does this work feel different for nurses now that it's a part of their daily routine? Misty, I'd love to hear from you if you don't mind.
Sure. So their first response is, how did we survive without this? Or how did we make things work without this, without having a bridge to utilize? And actually, this came to fruition our very first launch day. So we were all excited. We were utilizing a bridge for the first time with our very first patient. And of course, our DNV accrediting body shows up. So our surveyor shows up that very day. They're touring, and we let them know that we actually have this very exciting rollout that we're doing. She was just as excited as we were. So much so that she asked us, after we completed the first recording, if she could go in and speak to the patient. So we had not even had feedback from that patient, very first go live. So the surveyor goes in right after the recording, and the patient shared with the surveyor, "I don't know what was different, but that was the most informed I have ever felt during any assessment in not only this visit for my prior 4 days, but any visit at the hospital." And the surveyor was so impressed with the interaction with the patient and witnessing the abridged recording, that she collected all of her other 4 surveyors, and we had to demonstrate and do a demo for that survey team before they left campus. So it worked out really well.
That's
And I
fun.
think the other, yeah, the other very important factor is that with our nurses, we really were incredibly intentional about doing this in partnership. So we were doing this with them and not to them. They're part
Hmm.
of the care, so they certainly feel more informed, more in control, um, so that everybody is on board. They know what's going on. They feel confident about where we're headed, and they feel like they are heard in the decision making and how we're rolling that out. And I think that's really a key component to why our nurses are feeling so much more fulfilled. And they're really feeling the joy coming back to their work because we are able to highlight those human connections, and that is filling their buckets. Because as nurses, that is why we all do what we do. It's about the human connection.
Really appreciate that. Thank you so much. And Jill, love to hear your thoughts on this topic.
Well, as I mentioned, nursing feedback and input was very important to us. So we offered many opportunities to achieve this, whether that was through our QR codes for real time information and feedback, or those pulse surveys that we co-created with KLAS. Common themes that we saw included comments about not having to remember the things that they did or things that patients said, because it was capturing it for them, where historically they would have to turn around and remember every detail that had occurred and then document it. So seeing the things that it's naturally capturing just based on that conversation that they may have not have even thought to document is another common theme. For example, one nurse went into the room to capture a wound change and was pleasantly surprised to find that it had also captured that he did a one-person assist and had moved the patient from the left to the right side. So capturing those things that they never would have documented on their own. Looking back at a few direct quotes from our nurses on their experience, we had one nurse wrote, simply not having to worry about having to run to the computer, not have my attention directed towards my patients helps with both why I became a nurse and helps my interactions with my patients where I don't feel rushed. And another wrote, things that I didn't realize I was doing with my patients were being caught and put in the chart. And it was the most in-depth charting I have ever done. We had another nurse that commented that they actually feel like with ambient, they're spending more time in the chart, but that charting is better time well spent and is more meaningful to them. She had mentioned that she has time to do things that she never had time to do before, going through, doing in-depth, chart reviews, looking at patient summaries, and having a better idea of what's happening with that patient, which has been really meaningful to them.
Jill, I love that. Thank you for sharing some anecdotes, and those are great stories, and it's impactful. But there are also signals, right, of the real practice change that's happening at bedside. KLAS, we refer to this as capturing the invisible work nurses do. I don't know who came up with that. I'm going to take credit for it because it sounds really cool and pithy. But I think what you're both describing is exactly that. We noted in our research that meaningful momentum, it starts small typically, but it builds. And as confidence with the technology builds, we also saw that it really does have a multiplicative effect. So both of you have been on that journey now from pilot to a much broader rollout. I would like to understand now and help people who are watching understand what gave you the confidence to scale and what tactics actually moved that adoption. And Jill, we'll start with you here. I'd love to hear your thoughts.
Yeah, I would lean in on the nurses and their reaction to the tool and their utilization of it. We want their trust and we want their adoption. As Misty mentioned, this is a tool that they're a part of. It's built for them, with them, and that has really made a big difference. When we can show that they found ways to incorporate that into their day and their patient care, that tells me that we're doing something right. And additionally, we saw trends in their usage and satisfaction. So I was comfortable saying, okay, we're on the right track. This feels different. We've done what we've set out to do. And then we start introducing additional features and introducing it to more nurses, more units. I think it's also important to look at those adoption rates, the trust and documentation quality signals that are included. So things like measurements in row accuracy rate. So we saw a 94% row accuracy rate, which is determined by any modifications or acceptance rates by the nurses when they're reviewing and accepting that documentation. And then for drafted documentation, we saw 87% of those flow sheet rows, which was drafted again by ambient and saved by the nurses. So really good signals in their overall satisfaction.
Very helpful. Thank you, Jill. Misty, how about for you?
Sure. So we are in the midst of a house-wide rollout right now, and we had developed so much positive momentum with our pilot unit. We decided to have a little fun with it, and the other units were all so eager, begging for the Abridge tool that we did a TikTok competition. So we wanted those teams to tell us why you want the tool, how you can better serve and care for our patients, and why that would be beneficial. And now we have a very fierce competition of who gets the next tool, and we'll be selecting that unit in this manner. Another thing that we did, I believe, that was key to keeping the positive momentum going is we trained our float pool. So float pool was able to experience it on our pilot unit. And of course, float pool goes throughout the organization. So they were very quick to spread the word to the rest of the house, how great this is, how much the other floors need this. And they were essentially our internal salespeople, and they didn't even know it because they were sharing those experience with other units. And I think another key component, nurses typically are not encouraged by receiving a tool that is developed and rolled out by our IT partners, but nurses trust nurses. So we were truly the face of this rollout with our team. Of course, IT, our partners are wonderful, and they were very supportive on the back end, and we were doing this in partnership, but we were the ones, the nursing leadership team, to step forward in delivery and rollout of this product, which is something that we did with great intention. Because we would rather have the nursing teams pulling products and tools compared to us feeling like tools are being pushed on the clinical teams to use. And it just feels a lot different, and that we're truly partners. It was very interesting because a bridge gives us utilization visibility directly. So I can see with the data that's provided how many minutes of recording I have, how many different users. I can pull that data by patient. I can link that then to the patient experience surveys that we're seeing. And if a nurse has been a heavy utilizer and then it drops off, we really go into discovery mode right away to try to discover what's the barrier, what may that team member be struggling with, and we're at the elbow with them to work through those things. On our initial unit, I can share that we have had approximately an 85% adoption. So we did not make the utilization of a bridge mandatory, but voluntary. And we quickly have witnessed that adoption increase as we have nurses who are a little bit questionable about the product. They see the success that their colleagues are having, and they want to be part of that. So it's happened in a very natural way, which has been phenomenal. I can also share that nurses trust the quality signals, the data that we're getting back, and we have quickly seen that our row accuracy rate during documentation has been 95.5% accurate. So that is the amount of percentage that our nurses are accepting the first round of the interpretation of what they're communicating through the tool. So that is an exceptional percentage. And then of our drafted documentation, 88% of FlowSheet documentation has been saved by nurses and submitted as part of the permanent medical record.
One thing I want to draw out for the audience, Reid and Corewell, you both took meaningfully different paths to get to where you are now. The outcomes were very positive. There was different leadership models, different ways to get to it. I think it's an important signal, though, for anyone in the room who's trying to figure out what their version of this really looks like. And hearing your stories, I know, will be helpful. We have a lot of people watching this as well who are in earlier stages. Maybe they're just starting their journey, building that internal case, trying to figure out whether this is the right moment to move. Do we want to wait until more maturity happens? I'd love to just close with advice directly from both of you. And we'll hear from you again, Jill, first, if that's okay, and then Misty.
The partnership between the unit leaders, our informatics team, and our nurse practice team is critical. I think having that engagement with your practice partners, whatever that looks like for you, whether that's a nurse educator or CNS, but having a strong partnership and buy-in where you can work collaboratively as a team is crucial. This is not just about the technology. This is really thinking differently about how our nursing practice is and how we speak to our patients, how we care for our patients, and then what that looks like and translates into the documentation. So having that strong partnership really goes a long way and can further help increase a faster level of adoption and usage, and then ultimately seeing those positive outcomes.
And Misty?
Sure. So I would absolutely agree with everything that Jill just shared. The importance of the partnership between IT, between our Abridge team, and those first line team members. It was very crucial to get their feedback in the moment. And then where we saw opportunities to pivot, to take that feedback directly from them and make those changes swiftly so that they were quickly noticing that they're heard. So their feedback to continue to advance the tool was widely utilized. And then I think another key component for us was really focusing on clinician well-being. So our teams quickly understood that we wanted to bring the joy back to their work by providing and enhancing that human connection. So it was a way that they quickly noticed our intention behind it and were able to resort in higher utilization and adoption of the tool.
Super helpful. And just for the audience listening, what Misty and Jill have done, it doesn't just confirm what our research predicted and hoped for, but in several cases it actually exceeded what we expected and hoped for. It's a vacancy rate, like being cut nearly in half, patient experience jumping from below the 25th percentile, right? Misty, I think you said to above 75th percentile.
That's correct.
Overtime down 80%, patient telling an accreditor on day one, hey, that was the most informed I've ever felt at any hospital. And Misty, you put it really simply. I think care is happening with patients now. It's not happening to them. And Jill, your reminder about it only works if you stop treating it like a technology implementation. It's a different way of thinking. It requires change management and thinking about nursing, the practice overall, like how do we adjust that? At KLAS, again, we call this capturing the invisible work that nurses do at the bedside. They've been doing incredible work for so many decades, and now we're getting credit. And we're also elevating that patient experience and journey, which I think is so important. So Misty, Jill, thank you. The full first look report on ambient AI for nursing 2026 is available now, and the link will be in your follow-up email.